You have some questions. Okay. I have one quick question for Dr. Eagle. Is Dr. Eagle still listening?
I'm here.
Hey, Dr. Eagle?
Yes, can you hear me?
Okay. Yeah, I can hear you. Thanks. Despite being a surgeon, I was really interested in your survivorship data, looking at how the anxiety and all that stuff that affected patients after their recovery from their dissection. I'm just wondering what kind of things we should be doing. Is this more of a discussion that we should be having just in clinic within post-op? We have an aortic kind of survivorship group for patients who've recovered. But what else is there that we can do? Because it is pretty upsetting to get patients through this serious situation and then realize that they're still struggling massively with the after effects of surviving surgery.
Well, first of all, thank you again for the invitation to be part of this. Clearly, your aortic team is addressing many, if not all, of the facets of this that we talked about. I do think that the taking care of the acute event is a blur for patients and families, and the survivorship question really starts the day they walk out of the hospital, and as they gradually come to grips with the fact that they've survived. Now they have to ask themselves, how will I survive and what will my life be like? And like any trauma, I think this takes actually months to fully manifest in terms of their questions and our answers. So I really liked a couple of your presentations that talk about being methodical in addressing all of the various aspects of care and their knowledge of their care. And one of the questions I always ask after I'm starting to see these patients again at the end of the visit is, what are your fears? What are you afraid of? And remarkably, not infrequently, that's when really the truth comes out. I'm afraid that I'll never be able to run again. I'm afraid that I'll never be able to do other things that have been very important to me. So I think it's just a methodical addressing of physical, emotional, mental, sexual, all of that through that, especially that first year when they're kind of reestablishing the fact that they're going to make it. Do you know what I mean? And I think having all members of our team focusing on that and making it upfront is really, really important. We can't trust that they'll raise the questions because in their fear, they may be embarrassed, especially in front of a loved one, perhaps. So I don't know if I answered your question, but I think it's something that we need to chase repeatedly, systematically, especially in that first year after discharge.
You answered my question. Thank you very much.
Hi, Josh Levinson here. I have a question from the chat by actually one of our trainees about whether we should be able to fully rely on symptoms as an indication for whether the type A is really acute. I think Dr. Eagle sort of mentioned that sort of vivid memory of how acute the chest pain was. And so I don't know if he or others on the line want to give their thoughts on that question.
Well, I think it's in general, the experience that I've had has been exactly like what Dr. Eagle described, where, somebody knows something's wrong. And, when we talk to patients and they say, well, what do I do when they have an aneurysm? They say, well, what do I do if something happens? You say, well, listen, it's going to be like nothing you've ever experienced before, and you're going to know something is very wrong. And you need to go to the, show that card that Alyssa talked about and go to the emergency room immediately. I think there are patients who come in with incidental findings, and just about a week and a half ago, we had a patient come in with an incidentally found chronic type A dissection. And some of those that we've seen have been in post-op patients, as was mentioned before, who've had aortic cross-clamping, proximal anastomoses for coronary bypass and stuff like that. So I would say in general, the symptoms are very very descriptive of it being acute, and in settings where it's subacute or chronic, there's generally not that history of that very dramatic pain.
The only thing I would add to that is the symptom is not just chest or abdominal or back pain. The symptom could be a cold leg. The symptom could be, hemiplegia or hemiparesis. So it could be different. So because it's not uncommon for, and Kim has shown this to us multiple times, and we've learned this through IRAD, that there's just several number of patients that present without pain. And it's important to just keep that in mind, as this is really the ultimate masquerader.
Yeah, when we looked at a series of painless dissections in IRAD, and as you point out, some of them had a stroke, some of them occurred during surgery when they were under anesthesia, some of them occurred in the cath lab when they were sedated, some of them were patients who'd had prior surgery of the chest and perhaps had a loss of proprioception, in the chest area. Some of them were just very old and confused and had a hard time describing what they had for breakfast, let alone what was making them feel uncomfortable. But as you saw in the data, by and large, 5 out of 6 describe instantaneous, terrible pain, and most of the rest have fainted or had a stroke.
I think it's also important to remember that the pain can be confused with other sources of pain. Especially in our practice, we've seen a couple high-profile instances where there's been back pain that's been confused for something else, and the workup's been delayed, and you finally find the diagnosis, but there's a perinephric hematoma or maybe a kidney stone in someone with AKI who couldn't get a contrasted scan. So sometimes the delay in diagnosis can be a result of people looking for pain in certain places that don't put it together with aortic dissection or a rupture.
Yeah, thanks. That was a great session, everyone. I have a question for Dr. Eller regarding ophthalmology referrals. Whenever I diagnose somebody, I'm a cardiologist. Whenever I diagnose somebody with connective tissue disorder, I recommend ophthalmology follow-up. And I make it very clear it's ophthalmology, not optometry. Is that okay, or can optometrists serve as your gatekeepers before coming to you? Because I know there are more optoms than ophthalmologists.
So that becomes almost a political question these days, because every specialty has alternate pathways to cover. You have podiatrists and orthopedic surgeons and psychologists and psychiatrists, and the younger trained optometrists are trained pretty well. We have a number in our department, and I would say almost anyone in my department who's an optometrist would be adequately trained to look for ectopia lentis and retinal detachment. But I don't know if I can say, the older generation of optometrists were basically trained to just do refractions and contact lenses may not be as equipped to do that. So what I would recommend in that situation is you actually ask for a report and say, make sure they send me a letter, documenting what they saw in the examination. And I think that way you can be comfortable. I can remember many, many years ago looking at a malpractice case where a young diabetic woman was told from the high-risk MFM department at McGee, go get an eye exam because diabetes can accelerate in pregnancy. And she went to her 70-year-old optometrist and said, I came for an eye exam. And she came back to the MFM and they said, how was your eye exam? She said, oh, I'm 20/20. He gave me a new pair of glasses. But he didn't dilate her, he didn't look for retinopathy, he didn't ask if she was pregnant, she didn't mention that she was referred from McGee specifically for an evaluation, and her retinopathy progressed and she ended up blind. And so hopefully that answers your question. But I have a question. So I was told that sometimes general anesthesia can induce the amount of effort on a body as if running a 6K race. So when I see a patient with Marfan who needs eye surgery, whether it's retinal detachment or cataract surgery, what kind of clearance do they need?
Hello? Okay. Generally, I would when we get this question a lot, I usually still say it's a low-risk surgery overall, and I don't recommend any further testing prior to proceeding. And I would say that for a lot of kind of outpatient procedures, like eye surgery, colonoscopy, EGD, those sorts of things. Once you start kind of cutting open parts of the body, then I will be more concerned. But generally, those are such low-risk procedures for adverse cardiac events that I don't think they need any additional testing prior to pursuing them.
I have a question for the panel if we still have some time. I was going to ask, surveillance has been something that we've talked a lot about, as well as kind of a lifetime extension of this idea that everything related to these conditions is a lifetime thing. In vascular surgery specifically, we've had a lot of issues with follow-up and surveillance just in general. People get lost to follow-up because a variety of reasons. They are from far away, they forget. Sometimes life just gets in the way, I think somebody said earlier. In your guys' practice, and the members of the panel, how have you tried to encourage follow-up and surveillance so that people don't get lost and come back with ruptures or growth that's not tracked? Because I certainly personally have dealt with several of these patients. They have not done well. So any ideas or any ways that you guys have found that you can get patients to come back and continue to follow up and be surveilled for this?
So I can, this is Mark, can you guys hear me?
Yes.
Yeah. So as someone that's a family doctor that is all about continuity and continuing care of the patient, even though most of my EDS patients, I see them as the consultant, we see them on a regular basis, same with my Marfan's patients. And what we try to do is a multidisciplinary approach between myself, my team, which brings in nutrition, psych, and of course physical therapy, to continue to monitor them through the whole life aspect. And it's interesting as my career has changed from the Midwest to the East Coast. We probably have maintained about 70% of our patient care. Patients that we were seeing even in the Midwest, to continue giving them that longitudinal care that they need. I think it's imperative, what's been mentioned here is the lifelong component and the multi-team component. And this is more than just the aorta. There's this whole person and being around that. And I love the mention from Dr. Eagle and others looking at the psychological, the sexual, the physical, the emotional, because when you address that patient bonds, even more so with the whole process. So it's just really enlightening and reassuring for a person that's been working with this population for about 25, 26 years to hear that this is really blossomed. And just a kudos to everybody that spoke today.
If I could add to that, one of the things that I try very hard to do is to say to the patient, you can never run out of your medications. And if you're short, you have to call me, because when you run out of your medications, your aorta could grow and or rupture. And that's a totally preventable accident that you and I have to go after together, prevent together. Always in my sign-out note, I have what the cadence for the next imaging is, so that the last thing they see as they leave the clinic is that I need an imaging study in 2 years and a follow-up visit at that time. So I want them to not only see that the medications are going to be the same, any new medications, lifestyle plan, but also that there's an imaging cadence that we're agreeing to do together to reduce the chance that we would miss a silent growth in their aorta. So if I can get them to understand that at discharge, and it's in the note, I send the note to the patient and their family, not just the referring doctors, it helps cement in the messaging that I can't lose track of this. This is important.
I'll just echo that. Knowledge, like you said in your talk, knowledge is power, and really doing a good job of patient education when you see them, explaining the importance. I think a picture is worth 1,000 words, so show them what their aorta looks like, show them pictures of whatever condition they have, educate their spouse or their mother or whoever is coming to their appointments with them, because sometimes it's that support person that's on top of things, and we'll make sure they come on time to visits. And then make sure you make the visit as accessible as possible for them. Many of these patients may be traveling from long distances, coordinating multiple visits at one time. And then we have a social worker associated with our clinic who can help with transportation and other sorts of that to get them actually to their visit with us.
Great, that was an outstanding discussion, and we could probably keep going for hours or days talking about this. But you know, we really hope you all enjoyed and found today's program meaningful. I know I learned a lot, and I really would like to thank all the faculty and the panelists today for their outstanding contributions to the program. In closing, a few additional people I'd like to thank, most importantly, my co-directors, Drs. Arvind Huskbal, Rachel Torek, and Michael Singh, for their leadership efforts and their contributions in planning today's program. Our industry sponsors, including AtriCure, Artivion, Medtronic, Gore, Ethicon, Edwards, Pfizer, and CSL for their support for today's educational program. Angie Kanunan, of course, our program director, without whom none of this could be possible. James Ferris and his media team for the excellent production of today's event, and really to all of you who've spent time with us from across the world. And most importantly, a thank you to all the patients and families who continue to trust us with their care and really allow us the privilege to participate in their lifelong journey with aortic disease. Thank you once again. We hope to see you in 2024.